Welcome to the lecture on Chapter 2, Evidence-Based Public Health. Our objectives include explain the steps in the evidence-based public health process, describe a public health problem in terms of morbidity and mortality, describe the course of a disease in terms of incidence, prevalence, and case fatality, describe how the distribution of disease may be used to generate hypotheses about the cause of a disease. Furthermore, we will discuss approach used in public health to identify a contributory cause of a disease or other condition and establish the efficacy of an intervention. We describe the uses of qualitative data that complement quantitative data. Describe the process of grading evidence-based recommendation. We'll learn about approach to identify options for intervention based on when, who, and how. Explain the role that evaluation plays in establishing effectiveness as part of the evidence-based public health. So in this chapter, we'll look at how the evidence-based public health approach has been used to address the problem of cigarette smoking. So there are 5 basic questions that we need to ask that together make up what we call the evidence-based public health approach. The first question is the problem. So what is the health problem? Then comes the etiology. What is or are the contributory causes of this problem? Then recommendations. So what works to reduce the health impacts? Then comes the implementation. How can we get the job done? Comes the evaluation. How well does or do the interventions work in practice? So this framework is known as the PERIE process. So if the evaluation suggests that more needs to be done, the cycle can and should be repeated. So this is an ongoing process. So how can we describe a health problem? In describing a health problem, we need to address the burden, the course, and the distribution of disease. So let's look at the burden of the disease. The first step in addressing a health problem is to describe its burden of disease. That means the mortality and the morbidity due to a disease. Mortality means the number of deaths due to a disease, and morbidity is the number of people affected or disabled due to the disease. Next, we'll look at the course of the disease. So how often the disease occurs, how likely it is to be present currently, and what happens once it occurs. So for example, how often is people getting affected with rabies, and how likely is to be present currently. So what is the incidence of rabies? What is the prevalence of the rabies? And what happens once it occurs? So what is the course of the disease? Like what are the pathogenesis that happens, or not? What is the infectivity period? What's the incubation period? That's the course of the disease. Next, moving on to the distribution of disease. So the distribution of disease means who gets the disease, where are they located, and when does the disease occur. So that is the distribution of disease. So in order to further explain the burden and the course of the disease, we need to explain what is incidence, what is prevalence, what is infectivity or the case fatality rate. And so we'll look at few examples right now, okay? So what is incidence? It's the number of new cases of a disease that develop during a year divided by the number of people in the at-risk population. So which is the formula for it is number of new cases of a disease in a year divided by the number of people who are at risk for that disease. For example, according to Johns Hopkins Resource Center for Coronavirus, the incidence rate for coronavirus in Indiana is 1,469.96 per 100,000 people. So that is the number of new cases of coronavirus per 100,000 people in the population of Indiana. The link below is a link towards the Johns Hopkins Coronavirus Resource Center where you can check the global the trend and the global number of cases as well as in the US. So it gives you incidence, case fatality rate, cumulative cases, and such. So looking at prevalence. Prevalence is the proportion or percentage of individuals who have the disease at a point in time. So it is the total number of people who are affected by the disease. This is the number of new cases and number of existing cases. Okay, so it is the number of people who are affected at that particular time divided by the number of individuals who could potentially have the disease. So the prevalence is the number of people who are living with a particular disease divided by the number of people in the at-risk population. So looking at an example, what is prevalence and what is incidence? So differentiating prevalence and incidence. Prevalence is the number of diseases cases present in a particular population at a given time, whereas incidence is the number of new cases that develop during a specified time period. So the prevalence answers how many people have this disease right now, or how many people have had this disease during this time period. So between 2019 to 2010, 6 months period time, between December 2019 till June 2020, how many people had this disease. That is the prevalence. So incidence is number of people acquired the disease during a specific time period. So the number of new cases is answered by the incidence. Okay. So for example, diabetes. Another example is diabetes. It's the prevalent number of diabetes patient within the specified time period is the prevalence, whereas incidence is the number of new cases who had diabetes within the same time period. The example below is the prevalence of diabetes among coronavirus patient was about 7.7. So when they did this study, doing a systematic review and meta-analysis, they found that about 7.7% of patients with diabetes had corona, or 15.6% had hypertension, and 4.7% had cardiovascular disease, and malignancy was like 1.2% had of patients with malignancy also had coronavirus. They were looking at what is the trend of diseases or comorbid illness along with coronavirus. Another rate is case fatality rate. Case fatality rate is the proportion of deaths from a certain disease compared to the total number of symptomatic people diagnosed with the disease. So it is the number of deaths due to a particular disease divided by the number of people who got diagnosed, or symptomatic people diagnosed with the disease. So case fatality ratio of coronavirus in Indiana is 3.40%. That means if 100 people were infected with the virus, 3.40% or about 3.4% or 3 people would die of coronavirus. That's the case fatality ratio in Indiana according to Johns Hopkins Resource Center. So next question is, how can understanding the distribution of disease help us generate hypotheses about disease causation? To understand that, let's remember the example of John Snow, who identified that a particular bore well was responsible for spreading of this cholera among London people. So he tried to look at how much frequency or what are number of people, what's the incidence or prevalence of particular illness in the particular area, and he looked at and other locations, whatever the frequency of illness, and then he tried to associate why was there a difference in the frequency of disease, and then he found that it may be related to this particular borewell water, and there's the water that had been supplied by two agencies were from an area which was infected with garbage and feces So he identified some association and he found that, okay, this is how this disease spread. So that is basically here too. A lot of diseases can be traced back to certain causes. For example, your textbooks provide a lot of examples about lung disease when patients work in, or when the person work in mine industry, because of the higher incidence of silica. There's causes silicosis, and another association is when a worker is exposed to polyvinyl chloride, which is widely used in construction, the persons get an angiosarcoma. And then another study found that though in children in a town of Colorado Springs had higher incidence of brown discoloration of teeth, but they did not have much of cavities. When they studied much more about it, they identified that the water content had more of fluoride, which reduces the risk of cavities, but higher levels of the same compound leads to brown teeth. So the examination of the levels of fluoride led to the establishment of levels of fluoride that could protect against cavities without producing brown teeth. So these kind of associations and patterns could be identified through this when we study the distribution of disease. It helps us to identify what kind of demographic characters or behaviors or exposures lead to a particular kind of disease. So as a person, what are his demographics or behaviors or exposure lead to a particular disease? Or place, based on the geographic locations or non-physical connections, how did the disease or particular morbidity increases or decreases? In which time of the year or there is more frequency of the disease, for example, annual flu, which seasons do that is more prevalent? How do epidemiologists investigate explanations for changes in the distribution of disease? There can be changes in the distribution of disease over the period of their lifespan, or in the period of time period. Based on the time period, there can be changes in the distribution of disease. So there are three basic reasons that changes in rates may be artifactual rather than real. One is differences or changes in the interest in identifying the disease. For example, when there was new and effective treatment for HIV/AIDS, there have been an increased interest in detecting the infection. Next is differences or changes in the ability to identify the disease. Based on newer technologies, our ability to identify the disease were increased. The next is differences or changes in the definition of the disease. So based on the development of new opportunistic infection or newly recognized complications, the definition of HIV disease or AIDS-related disease has changed. So that may be contributing for the changes in the distribution of disease. How can epidemiologists explain these changes in the distribution of disease? So that is when we have to do some other forms of investigations or statistics like age adjustment rates. For example, they found that for lung cancer, the incidence of lung cancer was rising, and they said maybe it's because when people get older, they are more susceptible for lung cancer. So how can we just say that maybe it was not related to age, it was just related to the use of cigarette smoking? So that's when they had to do more studies to do age adjustment studies. So they've looked at the prevalence of the illness during younger age and also the older age, and then did studies to investigate if it was related to age or if it was related to smoking in itself. So when we explained the previous slide, we said something about confounding variables, right? So the confounding variables are other factors that may be involved in causing a problem. In order to say that a particular etiology or cause caused this problem and not another variable, the epidemiologists need to do different forms of studies. So a group association is a hypothesis about the cause of a disease without having information on specific individuals within the group. So for example, in your textbook, it says that there is higher mortality rate from drowning in southern states than in northern states in the United States. And the per capita consumption of ice cream is also higher in southern states than in northern states. So there's a group association which is established between ice cream consumption and drowning. So when you think about this, you soon realize that there's another difference between southern and northern states. The average temperature is higher in southern states. So the higher temperatures are most likely associated with more swimming and also more ice cream consumption. So ice cream consumption is therefore related to both swimming and to drowning. So we call this type of factor a possible confounding variable. Having an ice cream, consuming an ice cream is a confounding variable. It is not directly causing this drowning. More swimming may be causing more drowning, right? So in this situation, there is no evidence that those who drown actually consumed ice cream. That is, there is no evidence of an association at the individual level. So group associations can be misleading if they suggest relationships that do not exist at the individual level. So that kind of variables are called confounding variables. There is no direct causage, but there are these variables causing some association. This is called the confounding variables. So next we will discuss about the etiology. So how do we establish contributory cause? So we said ice cream consumption causes drowning. That was a confounding variable. Maybe more swimming caused more drowning, right? So in order to say that, okay, this might be contributing to more drowning, or more swimming within itself does not cause drowning, there may be something else that was contributing to drowning, right? So what are the contributory causes that caused this problem? There are three definitive requirements to say that a particular cause produced this effect. First is the cause is associated with the effect at the individual level. So that is, the potential cause and the potential effect occur more frequently in the same individual than would be by chance. Therefore, we need to establish that individuals with lung cancer are more frequently smokers than individuals without lung cancer. That is one requirement. Next is the cause precedes the effect in time. That is, the potential cause is present at an earlier time than the potential effect. Therefore, we need to establish that cigarette smoking comes before the development of lung cancer. The third requirement is altering the cause alters the effect. So that is, when the potential cause is reduced or eliminated, the potential effect is also reduced or eliminated. Therefore, we need to establish that reducing cigarette smoking reduces lung cancer rates. See? So in order to study these are the three definite requirements. One is cause is associated with effect, cause occurred before the effect, and altering the cause alters the effect. So based on these requirements, the epidemiological studies differ. So first, to identify group association, we do population or ecological studies. We're looking at the larger amount population, ask them looking at them and identifying what is the probable risk factor for a particular illness. That is a population study. So in order to pinpoint and say this particular cause caused this particular effect, then we have to do the case control study or individual association. In order to identify individual association, we do case control study. This, for example, is during the 1940s and 1950s, the individuals who developed lung cancer were far more likely to be regular smokers compared to individuals who did not smoke cigarettes. So, for example, in that particular case, they looked at patients who had lung cancer and we had control population who did not have lung cancer. So the control did not have lung cancer. The disease was not there. And then they looked back and asked them if they were regular smokers. So people who had lung cancer said, okay, they were more of regular smokers in that criterion. But in the control, there were less number of people who were regular smokers. So there was an individual association between cigarette smoking and lung cancer. That is case control study. Then moving on to the cohort studies. So that is cause precedes the effect. So cigarette smoking caused lung cancer. So cohort studies are kind of longitudinal studies. So we are looking at people with smoking or without smoking. We are looking at people who are regular smokers and who are not regular smokers, and we are looking over a course of period and looking at them and see if they've developed lung cancer or not. So people who were regular smokers, when the American Cancer Society did a study over 3 years, they found that people who had regular smokers had more of cancer, whereas people who were not regular smokers did not have lung cancer. So that is a cohort study. So cause precedes the effect. Next is altering the cause alters the effect. Those can be studied by using randomized control trials. That is, there's a experimental group and there's a control group. Okay, and the experimental group is given a particular risk factor, and we have or particular treatment, and then we are looking at what is the effect. But in most of epidemiological studies like cigarette smoking or lung cancer, we cannot give this healthy control or healthy people to start smoking and tell them, okay, we are looking at your effect of smoking on you by introducing the smoking. We cannot do that, right? So that's when ethics of studies come up. So, but in other cases, like but maybe in case of that's why most of the things like this can only be studied on animals or rats. Even then, the ethics plays a huge role there. So what can we do if all three requirements don't definitively establish contributory cause? Let's take the example of cigarette smoking itself. We cannot ask a healthy person to start more smoking and then look at what is the life trajectory and look at if they developed lung cancer or not. So that is not ethical. So now we have to look at supportive or ancillary criteria. That is, we have to look at the strength of the relationship. What is the dose-response relationship? What is the consistency of the relationship? And what is the biological plausibility of the relationship to establish the contributory cause? So let's look at this ancillary criterion. And first, the strength of the relationship. The strength of the relationship can be identified through a statistics known as relative risk. Okay, so relative risk for cigarette smoking is calculated by probability of lung cancer for cigarette smokers divided by probability of lung cancer for non-smokers. So strength of the relationship means that the risk for those with the risk factor is greatly increased compared to those without the risk factor. For in this case of cigarette smoking and lung cancer, the relative risk is 10, which implies that the average smoker has more than 10 times the probability of developing lung cancer compared to non-smokers. So even relatively modest relative risk may make important contributions to disease when risk factor is frequently present. So a relative risk of 2, for instance, implies a doubling of the probability of developing a disease. So that is strength of relationship. Next is dose-response relationship. It is higher levels of exposure and a longer duration of exposure to the cause are associated with increased probability of the effect. So studies of cigarettes and lung cancer established that smoking half a pack a day over an extended period of time increases the risk compared to not smoking. Smoking 1 pack per day and 2 pack per day further increases the risk. That is the dose-response relationship. But the caution is no dose-response relationship may be evident between no smoking and smoking 1 cigarette a day, or between smoking 3 or 4 packs a day. Next is consistency of the relationship. It implies that studies in different geographic areas and among wide range of groups produced similar results. So studies at the individual level produce similar results in multiple locations among populations of varying socioeconomic and cultural backgrounds. That is the consistency of the relationship. Hundreds of studies in multiple locations and populations consistently establish an individual association between cigarettes and lung cancer. But the consistency requires the availability of numerous studies that may not have been conducted. So the last criterion was biological plausibility. That is, there are known biological mechanisms which can convincingly explain a cause and effect relationship. So there are multiple toxic elements in cigarette smoking which may be causing the lung cancer. So cigarette smoke directly reaches the areas where lung cancer appears. So now we summarize the approach used in evidence-based public health to establish a contributory cause. So let's look at how we summarize this process and how it applies to cigarette smoking and lung cancer. So first is at the population level, or doing the ecological studies, we compared population rates between an exposure and the development of lung cancer. And the second one was the individual association, where we found that cigarette smoking had an association with lung cancer. We did the case control study to help with individual association. So cases with the disease are compared to similar controls without the disease to see who had the exposure of cigarette smoking. Next is the requirement number 2, that is the So the next requirement is to associate the requirement number 2, that is the cause precedes the effect. So in this study, we did the cohort studies. We followed individuals who were exposed and non-exposed, and then over time if they developed the disease or not. So in cohort studies, the exposed and similar unexposed individuals are followed over time to determine who developed the disease. Next is altering the cause alters the effect. So active intervention to expose one group to the risk factor results in a greater chance of outcome. So we said that these studies are not always ethical or practical. These randomized controlled trials allocate individuals by chance to be exposed or not exposed are needed to definitively establish contributory cause. So what does contributory cause imply? The existence of a contributory cause implies that the cause increases the chance that the effect will develop. For example, in cigarette smoking, having a cigarette smoking increases the chance that a person might develop lung cancer. But not everyone with cigarette smoking develop lung cancer. So that is the contributory cause, okay? It means that cigarette smoking increases the chance that the effect will develop, but it does not say a causation that this will cause lung cancer. So its presence or the contributory cause presence does not guarantee that the disease will develop, nor does the absence guarantee that the disease will not develop. Let's look at recommendation. What works to reduce the health impact? There are a lot of interventions available for us. So which is best for us? So that brings us the question of quality. The best, highest quality evidence is available from randomized controlled trials. And more than randomized controlled trials, systematic reviews and meta-analysis brings us the best quality of evidence. And a magnitude of the impact can be identified from benefits minus the harms, or the net benefits. This brings me to the topic of hydroxychloroquine for coronavirus. Many said hydroxychloroquine is good for us, and the lesser chance of contracting serious serious illnesses by even though we get coronavirus. But the harms were more from hydroxychloroquine than taking it. The benefits were lesser when compared to the harms. So that is why the scientists or CDC or WHO said not to take hydroxychloroquine. So the what is recommendation is based on the benefits and compared to the harms of the particular recommendations. So evidence-based recommendations combine the score for the quality of the evidence with the score for the impact of the interventions. These two aspects can be combined to produce a classification of the strength of the recommendations graded as A, B, C, D, and I. So A means net benefit is substantial, B is moderate, C is net benefit is small, and D is zero or negative effect. So I is again poor or insufficient evidence, or net benefit is zero. Insufficient evidence is I. The classification of recommendations: A is substantial, B is moderate benefit, C is small benefit, and D is zero and negative, and I is insufficient evidence. So most of our community prevention efforts are in between a grade of A or B. Next is implementation. How do we get the job done? To examine the options of implementation, we use the when, who, and how approach. So looking at when, it asks about the timing in the course of disease in which an intervention occurs. The timing allows us to categorize interventions as primary, secondary, and tertiary. Then is who. Who is at whom should we direct the intervention? Should it be directed at individuals one at a time as part of clinical care? Or should we direct at a group of people such as vulnerable population? Or should it be directed at everyone in a community or population? Like we explained, at-risk population or the population as a whole. And now finally, how should we implement the interventions? So there are three basic types of interventions when addressing the need for behavioral change. These interventions can be classified as information, motivation, and obligation, that is requirements. So how can we implement these interventions? So let's look them in detail using an example. Based on when, the interventions can be categorized as primary interventions, secondary interventions, or tertiary interventions. So the primary interventions take place before the onset of the disease, that is prior to disease or condition. For example, your seatbelt recommendations or walking or exercise, these are all primary interventions. Secondary, that is prior to the symptoms, that is early screening. Okay, secondary is when early diagnosis and treatment. So you go for screening, you identify you have an illness, and you treat them. That is a secondary intervention. Tertiary is rehabilitation. That is prior to irreversible complications. You had the disease and you prevent disability or death from occurring. That is using your tertiary intervention. That is you rehabilitate the patient. That is the tertiary interventions. So who it should be directed? At individual level, at-risk group, or general population or community. And how? Through information, motivation, or obligation. So again, we are explaining what is primary, that is removing the underlying cause, increasing resistance, or reduce exposure through primary interventions. Secondary is post-exposure interventions. Identify and treat risk factors or screen for asymptomatic disease. One example of secondary prevention is you're screening for mammography, you're screening for testicular cancer. These are all secondary interventions. Then tertiary, reverse the course of disease or cure or prevent complications and restore function is tertiary. After a stroke or after an MI, you do more of rehabilitation and you come back. You try to prevent that disability. That's the tertiary interventions. So who again, individual often equals the patient care. At risk implies groups with common risk factors. And general population includes defined populations with or without a risk factor. So at the individual means the clinical care. At risk means we are targeting a population who are at more prone for particular illnesses. For example, if you target a population with HIV/AIDS, that is at risk population, then we are targeting all the interventions at the general population is the third level. Again, information, efforts to communicate information and change behavior on basis of information, motivation, rewards to encourage or discourage without a legal requirement, obligation, it is required by law or institutional sanction. Okay. Next, with the example, how we explain. Primary, prevention of smoking, reduction in secondhand exposure, that's a primary intervention. Secondary is assistance in quitting, screening for cancer if recommended. Tertiary, healthcare to minimize the disease impact. For example, you develop COPD, you developed cancer, you undergo treatment to reduce the impact. That's a tertiary intervention. Who? Individual, you're looking at the smoker itself. At-risk groups at risk for smoking or disease caused by smoking, example, adolescents, as well as current and ex-smokers are targeted. Population, the entire population, including those who never have or never will smoke, is considered the entire population. So one information example is stop smoking campaigns, advertising, warning on package, and clinician advisor example of information. Example of motivation is taxes on cigarettes, increased cost of insurance, that is motivation. Obligation is prohibition on sales to minors, exclusion from athletic eligibility, and legal restrictions on indoor public smoking. These are obligation examples. Then again, looking at the individual, when clinician provides the patient with information explaining reasons for changing behavior. Example, clinician distributes educational packet to a smoker and discusses his or her own smoking habit. Who? Clinician encourages patient to change behavior in order to qualify for a service or gain benefit. Example, clinician suggests that financial savings from not buying a cigarettes be used to buy a luxury item. Clinician denies patient a service unless patient changes behavior. Clinician implements recommendation to refuse birth control pills to women over 35 who smoke cigarettes. That is how they implemented the individual level. At the high risk group, how can this be implemented? When information is made available to those who engages in a behavior. Example, warning labels on cigarette packages. Who? Those who engage in a behavior are required to pay a higher price. Taxes on cigarettes is who. And how? Those who engage in a behavior are barred from an activity or job. Example, smokers banned from jobs that will expose them to fumes that may damage their lungs. Next is population. Information is made available to the entire population, including those who do not engage in the behavior. Example, media information on the dangers of smoking. Who? Incentives are provided for those not at risk to discourage the behavior in those at risk. Example, lower healthcare costs for everyone results from reduced percentage of smokers. An activity is required or prohibited for those at risk and also for those not at risk of the condition. Example, cigarette smoking banned for those under 18. That is how they target the implementation at the population level. Next aspect is how do we evaluate the results? It's a critical measure to identify how much of the problem has been eliminated by the intervention and what is the nature of the problem that remains. Here we have to look for another framework called the RE-AIM framework. It is used to evaluate how well specific interventions work and were accepted in practice. RE-AIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. Reach meaning is who is the intervention being applied to or who is the target population. Next is effectiveness. It asks what is the impact in practice on the intended or target population, including the beneficial outcomes as well as the harm. Next is how well is the intervention accepted in practice. This can be identified through adoption, implementation, or maintenance aspects. Adoption is how well the intervention accepted by individuals and providers of service. And implementation, how should the interventions be modified to reach target population and providers of services, but not those for whom the benefits do not exceed the harms. For this example, as a black box warning is placed on the prescription information, warning clinicians of potential suicide risk when used for teenagers. That's in implementation. Maintenance asks, how can we ensure long-term continuation of use and successes for interventions among individuals or providers of services? So that maintenance phase is long-term use of smoking cessation drug and behavioral change interventions are needed and are encouraged by coverage by health insurance plans. That is the maintenance phase. So the evidence-based the complete PURI approach can be explained by problem. We're looking at the burden distribution and making a hypothesis, looking at the etiology. We're trying to find individual association, cause precedes the effect, and altering the cause alters the effect. Based on that, we have recommendation, we look at benefits, we look at harms, and we look at cost. Is it the intervention cost effective? Then after implementation, when can be implemented, who is targeted, and how is it implemented? And then evaluation using the re-aim approach. So this concludes the chapter 2. So in evidence-based public health approach, we start by asking what is the health problem and what is the burden of disease or the health problem? What is the course of a disease or other health problem? And does the distribution of health problem help generate a hypothesis? And what are some contributory causes? And has an association been established at the individual level? Does the cause precede the effect? Has altering the cause been shown to alter the effect? What works to reduce the health impact? What is the quality of the evidence for the intervention? What is the impact of the intervention in terms of benefits and harms? What grade should be given to indicate the strength of the recommendation? How can we get the job done? When should the implementation occur? At whom should the implementation be directed? And how should the interventions be implemented? And then we looked at how well does the intervention work in practice? How well does the intervention work in practice on the intended or target population? How well does the intervention work in practice as actually used? How well is the intervention accepted in practice? Thank you.